give a very short introduction of our next and last speaker, who's Francesca Sirna, who is a research fellow at the CNRS, the National Health Research, the National Research Institute in Marseille at the Centre Norbert Elias, and who is also a fellow of the French Collaborative Institute on Migrations. Francesca's main topics of research are the migration patterns of healthcare professionals, as well as the ways in which gender relations and transnational families play into patterns of migration and the experiences of international healthcare professionals. So Francesca, the floor is yours and you have 20 minutes. Thank you very much.
Thank you, Maria, for inviting me to present and to join this international conference. Thank you for inviting me to share my work. Today I will present a first analysis of my field research on the international mobility of European and non-European health workers in the southeast of France. And my work is at the critical juncture of the sociology of migrations and the sociology of health. Next slide, please. So I would like to tackle, next slide. Sorry, could you? Right. I would like to tackle 4 issues. The previous one. Methods, comparison of European and non-European health workforce professional status in France, comparison of pathways in the frame of global economic crisis and budgetary cuts and rationalization in tasks in the health sector, and different perception of the pandemic according to origin of degrees but also gender. Next slide, please. I will focus this PowerPoint on doctors with degrees obtained inside and outside Europe, even if I met nurses and midwives too. And my work aims to analyze this specific geographical and sociological mobility in the context of the global social, political, economic, and health crisis. I met actually 30 persons, but I have just 24 usable biographical interviews. Next slide, please. So the economical, political, social, and migrant crisis have led to the strengthening of control over Europe's borders beginning in 2004 and pursued even nowadays in order to limit irregular migration. On the other hand, we also observe increasing elite migration trends. And as a matter of fact, the integration into the European Union area of new Eastern countries, along with the automatic recognition of qualification and degrees, has produced competition between Europeans and non-Europeans in the French health labor market, but also processes of exclusion linked with the origin of degrees and gender. Next slide, please. The economic crisis and the enlargement of the European Union produced a migratory flow of physicians coming from these new European countries, as you can see. This happened despite the historical links that France maintains with the African countries, Maghreb and the former colonies of sub-Saharan Africa. But before analyzing this process of selection and recognition of degrees and their effect on the migratory pathways, I would present some characteristics of the French NHS. Next slide, please. So the French healthcare system faces several convergent challenges. The growth of French population, effect of positive fertility and increase of life expectancy, a narrow application of the numerus clausus in medical schools, and the rise of so-called medical deserts, that is the great difference between urban and rural areas in terms of medical structure and number of physicians per inhabitant. Shortage of medical staff in urban and rural context, and budgetary rationalization and lower requirements also for healthcare sector. Recently, France decreased the requirements in health sector and tried to introduce the lean management, healthcare line production stemming from Toyota factories. And burns out and suicide rise in several hospitals where this method of management was introduced. Next slide, please. As a consequence of this shortage, foreign qualified physicians have been hired since 1980s. As you can see, quite half are European, and more than 54.5% are non-Europeans. That can be explained as a post-colonial inheritance of French education and health policies. Since 1974, international agreements and conventions between France and former colonies allow a temporary access to medical practice of facilities in obtaining visa to come to study in France and to work as intern in public hospitals. Next slide, please. These foreign physicians have several professional positions, especially created in 1987 and 1995. Associated attached physicians, a contract up to 1 year renewable, contractual assistant medical practitioner, 2 years contract, normally reserved for non-European physicians, but also practitioner acting as intern, up to 6-month contract. And these are professional contemporary positions used if any intern can be provided, often reserved for foreign qualified medical doctors, European and non-European. These three professional figures lead with precariousness of employment. They cannot be renewed twice in the same hospital, and non-European physicians must go abroad in other public hospital or in other town to find new job opportunities. They suffer for overloaded working schedule and medical repeated guards, despite the national and the European legislation. And their wages are lower than 50% compared to the colleagues having a French degree. Next slide, please. So I would stress that the presence of foreign physicians is lower in France than in other countries. This is because French medical practice has always been close to foreign physicians. But according to politicians' point of view, these foreign students had to come back to their native countries. They are just birds of passage, quoting Michael Piori, and their presence is just an opportunity to acquire a skilled degree in France in order to practice medicine once back. During the last 30 years, French health policies hesitated between increasing or limiting the number of non-European physicians, shifting from a post-colonial management of health and educational policies to a protectionist behavior in order to protect physicians' economic way of life, and recently to an industrial management of healthcare. So to counter the presence of these foreign physicians, the existing legislation provides a hard exam, only 3 times a life, to recognize the non-EU degrees and to allow physicians to settle in the private or public health sector. And therefore, only few succeed. But as a matter of fact, these non-European physicians allowed French hospitals to work by reducing costs and by providing medical specialization in shortage. Recently, French government decided to stop this process, arguing that they want to end up with a discriminatory system. On the other hand, the same government prefers hiring European physicians, trying to limit the presence of those non-European. Next slide, please. Analyzing their pathways, I would stress that non-EU physicians arrived before the global economic crisis. They wait from 10 to 14 years before their degree is recognized, and men are often hired as associated attached physicians, attaché associé, or practitioner acting as intern. And women are more often hired as nurses by their practice as physicians, but the earnings are lower than those of their male colleagues. Their professional path is characterized by a low international mobility because they have more difficulties to cross borders and to go in foreign countries, and this led them to settle in France. But on the other hand, they have high internal mobility because they have to seek job opportunities everywhere in France. Sometimes they have several medical qualifications to increase their chance to be hired. And they do not plan to return in their country of origin. Next slide, please. This map was elaborated by Victoire Cotreau. She's a geographer and she works on doctors with a non-European degrees in France, especially in Nouvelle-Aquitaine, a Middle West region in France. And this is Nahid Trajectory, a French physician with a Syrian degree. And as you can see, he moved from a region to another, seeking professional opportunities, almost in small hospitals during 9 years. Next slide, please. For EU physicians, mostly arrived during the economic crisis in 2007-2008. But analyzing the European physician trajectories, we can say that even if their arriving in France matches fewer difficulties than their non-European colleagues, their careers are less successful than their French colleagues, and not so many of them hold executive positions. Men and women are willing to move abroad to find better work and life conditions, but do not plan to return in their country of origins. And I can observe less gender differences in their professional path. Next slide, please. So for both groups, we can say that physicians face difficulties associated with their professional integration, but those are often interpreted as opportunities for personal and professional realization. They claim for their flexibility and their adaptability compared to French colleagues, and generally they hold medical specialization left by French students, such as radiology, cardiovascular surgery, nephrology, urgency, psychiatry. And there is no claim to simplify the procedure of degrees recognition or to improve their status. And they consider their move more as an international mobility of high-skilled professionals rather than migration due to economic reasons. Next slide, please. So during the pandemic crisis, I had a weekly call phones with nurses and physicians that I met before the lockdown. And these conversations have become moments of release rather than interviews in a traditional sense of term. So I must listen to complaints. Next slide, please. At the same time, media discovered, you can scroll down from 15 to 18 as you prefer. At the same time, media discovered suddenly the same presence of these foreign medical staff by publishing a lot of articles and reports on these doctors who keep French hospitals running. You can scroll down, please, from 15. Yes, you can see the articles. Next, please. Yes, next. So, during the phone calls with health workers, some differences on perception on the pandemic are observable, and they are often linked with their status. For staff with the non-EU diplomas, they often work far from home, and during the pandemic, they often do not return home to limit transport time, but also to avoid contaminating family and friends. And this is an additional difficulty in a long integration and recognition process. They're concerned about the future and their status, but also they hope that the pandemic will help speed up the procedures for recognition of diplomas. And the awareness of colleagues, patients, and authorities of the role played by these foreign professionals could lead to a reduction of discrimination. Next slide, please. For staff with European diplomas, the familiarity with their NHS sometimes less efficient, allows these professionals to put the situation of French hospitals into perspective and to make a more positive view of the situation despite the current crisis. They have often been able to organize transfer of patients to hospitals in neighboring countries, but also to exchange with colleagues in their country of origin on the protocols to be followed. And the collective awareness of their role within the French public hospitals gives them hope for upward careers and positions of responsibility. Next slide, please. You can click 4 times, please. Thank you. So just to conclude, at a national level, the origin of degree determines a selection of physicians and slow down careers, insecurity, and lower earnings. A process of de-skilling is at work for both groups, European, non-European physicians, and foreign physicians, mostly non-European, can be hired and fired depending on governmental policies and on the needs of hospitals. And non-European doctors are made to disappear in favor of Europeans. European policies of inclusion and exclusion of new countries into the EU shape also the health sector, generating discriminatory processes. But these latter are invisible and are mainly linked to nationality. That is, there would be hierarchy in the health sector leading with geographical origin of qualifications. But this workforce is also essential to the good running of the French public health system and the budgetary balance. And gender determines a different treatment, mostly for non-EU physicians. So my hypothesis is that they are at the intersection of gender, class, and ethnic process of exclusion. I also wonder if COVID marks an acceleration of the process of dismantling the public health service and privatization of healthcare, because private hospitals have also shown their capacity to manage the crisis. Softening the condition for practicing the medical profession without any assurance of regularization of the situation suggests that this profession could be used later as reserves of or support staff whose medical skills are used at a lower cost. So I wonder, will the pandemic speed the privatization process and increase the health workers' mobility who could be hired and fired according to the need of the health system by identifying a pool of skilled and low-cost labor? Next slide, please. More widely, international mobility of high-skilled workers should be questioned and deeper described to better understand the process of dealing with social and economic inclusion, exclusion, and discrimination. Thank you. Last slide, please.
Thank you very much, Francesca. This was a very complimentary presentation to the first three. So I guess we have to think about discrimination not only from the healthcare system to patients, but also within the healthcare system. And of course, that adds to the complexity of the processes that are at play.